the team just updated us like Tuesday. And you were kind enough to respond, but you were traveling, So.
Your voice is a little bit muffled.
Okay.
This is better.
Is it better now?
Yeah, it's much better.
Okay, fantastic. I will just I will not use the headphones and stuff. Yeah. Yeah. So no, thank you. This is like Dr. Mukherjee is doing every month, for with us, and we'll be starting other subspecialty also. So by the tail end of the month, we're doing with him for GI, and by middle of the month, we'll be changing the subject every month type of thing. Yeah. So yeah, let's okay. It's surprised, like if you are on time and like okay, perfect. Looks like that. Uh, we started getting people. Yes, okay. And oh, everybody's here. Hey, Dr. Lovejoy, how are you?
Hi, good morning.
Good morning. Let's see who else is here. Okay, perfect. Hey, Dr. Lavingia, how are you, sir?
Hi, good morning.
Good evening. We have Dr. Dodal. He's a radiation oncologist. He's here. Dr. Surabjit, he's the, I will do formal introduction in a minute, but he's a GI oncologist. Like, and he led successful webinar last month. He's kind enough to do the second one here. And, okay. And we'll give one more minute before we'll do the introduction and stuff. Is it fair? Okay. Okay.
Hi, Dr. Mukherjee. Ashish Gupta here.
Hey, Ashish, how are you, sir?
Hi, how are you? You have one of my favorite people in the world on, so I said I had to join the call.
Thank
you, Ashish.
You're very kind. Thank you all. Yes. Okay. And it's Dr. Pant here, Sarabjit, if you to see. Okay. Hey, Dr. Plant, how are you?
Hi, Sarji.
Okay. Okay, fantastic. Yes, I don't want to waste time with this thing. And so welcome everybody. And again, I'm Dr. Ashish Shah. I'm the orthopedic surgeon practicing at University of Alabama, Birmingham, US, and founder of SecOpp. I'm thankful to all of you for joining for this webinar. And again, like, with the busy schedule and the cricket match going on, for those people who can't just attend, we have that on the YouTube as well, right? So that's why we record this, and that could be telecast or can be seen in the future. I will not take much of time. First of all, Dr. Sarabjit Mukherjee, thank you. He's running this webinar second time in this 2 months. He's a chief of the GI Medical Oncology at Miami Cancer Center, South Florida. Thank you for inviting Dr. Pant. Welcome, Dr. Pant. He's a medical oncologist at the MD Anderson Clinic. He's a fantastic reputation in the pancreatic cancers, and is very well published in that area as well. So as on the Indian panel side, Dr. Lavingia, He is the medical director at Shelby Hospitals, and his special interest in GI. He has contributed with the webinar in the past as well. So as Dr. Mondal, he's a radiation oncologist in Delhi, and he's also very well published and well reputed in the society there. So as Dr. Shailesh Puntambekar and Dr. Aditya Naragan, they don't need any recognition from my side. They're all very well reputed surgical oncologists in their training with the next generation, or already trained next generation of the surgical oncologists in India and all over the world. And the last thing for me is Zoetic Pharma. They have helped us to reach out to the next generation of the oncologists and current generation oncologists, oncosurgeons in India as well. Thank you, Dr. Sarabjit and Dr. Pant. You can just take a lead, and I will stop.
Thank you.
Thank you so much. So again, thank you everyone for joining this webinar. And I know you all are so busy, and I really appreciate you taking time to join us and talk to us about pancreatic cancer. So the way we did it last time, we presented some cases, and we didn't want it to be very didactic. So we basically wanted to talk about cases and ask our colleagues from both US and India to see how they would approach this case. We would discuss where our practices would converge and where they would diverge. So the way I structured the session today is we would discuss 3 different cases in pancreatic cancer, and each with a special molecular driver. And we would go to each of you and see how you would approach this case at your institution, and where are the limitations and where are the challenges. So we'll talk about all of that. So I would start with the first case, which is a BRCA2 mutated metastatic pancreatic adenocarcinoma. But before that, I want to share my slide. Okay. Are you all able to see my screen? Perfect.
Yes.
Our first case is the BRCA mutated metastatic pancreatic adenocarcinoma. So this is a 72-year-old male patient who was diagnosed with metastatic pancreatic adenocarcinoma. At the presentation, patient was found to have liver and lung metastasis, ECOG PS of 1, CA19-9 high, 2450. And the patient had a somatic next generation sequencing testing, which revealed BRCA2 pathogenic mutation. So we sent for germline testing, and I would like to go to each of you and ask how would this information of somatic BRCA2 mutation would influence your choice of first-line chemotherapy? Would you start with FOLFIRINOX? Would you consider GEM-CIS, given the patient is a little bit on the elderly side? Would you consider Gem-Abraxane, or would you wait for germline results before deciding? So maybe I'll start with Dr. Pant, and then we will go to each of you.
Yeah. So thank you, Sarabjit, and thank you, Dr. Shah, for bringing the forum together. It's exciting to kind of look at the next generation of physicians in India. So just an introduction, before in India, I was born, brought up in Delhi, went to Maulana Azad Medical College in India, and then, came here for my residency and fellowship, and have been in Anderson for almost a decade. And, obviously Sarabjit, worked with him at University of Oklahoma, superstar fellow, obviously very, he's done amazingly, he's just doing amazing work. So we were really proud of him. But coming to this, Sarabjit, I think, so what happens is, when a patient comes to MD Anderson, maybe I'll go with that. So let's say a newly diagnosed metastatic pancreatic cancer patient comes to MD Anderson. We do both genomic testing, the somatic testing, which is in the tumor tissue. We do ctDNA, though it's, that's a longer discussion about like what percentage is positive in patients. So we tend to do somatic testing, and then we tend to do germline testing. And germline testing, as everyone knows, is kind of standard of care. I was part of the ASCO metastatic pancreatic cancer guidelines, so we recommended that to do that in patients. If you have a BRCA2 somatic mutation, again, it's in the tumor tissue, you would think it's in the germline also. That means that's, that's genetic. However, it doesn't always work that way. Sometimes you can find a BRCA2 somatic mutation, not find a germline mutation. However, one thing we know, we're going to discuss targeted therapies in this, but one thing that we know why it's so important to do the germline testing is not for the targeted therapy, I think so, but it's for the platinum exposure. So we have shown that platinum is very important to these patients. So in this patient, I would, instead of doing, let's say, Gem/Abraxane, which I may do in some patients, I would potentially either give FOLFIRINOX. I'm actually a big fan of Gem/Cisplatin also. I've had some really good success with the gemcitabine and cisplatin. So I would give the patient a benefit of the doubt. I would say, well, though our data for platinum in somatic is not that great as germline, but there is a chance this patient might have germline, which is a high percentage chance. So I would think about FOLFIRINOX or Gem/Cis. Coming to D, wait for germline testing. Pancreatic cancer patients, I feel like every week that we spend extra is a week that they are behind. Because I've had patients who come to me and within a couple of weeks, they're in the hospital before we are starting. They're in the hospital, bilirubin's gone up, they've obstructed the bile duct, they're getting septic, there's a lot of things can happen. So I try to start my pancreatic cancer patients as early as possible. So I know that was a long-winded way of giving that answer, but I would go for A or B would be my choice.
Thank you so much, Dr. Pant. Now I will come to our Indian colleagues. How do you approach such cases? Is germline testing standard of care for most, if not all, patients? Just to give you a little bit of background, we do the same as Dr. Pant mentioned. When a patient walks into our clinic, we order both germline testing and the somatic NGS testing. ctDNA is still not standard, but we do order that as well. So I would like to know how our Indian colleagues approach. So maybe Dr. Levin, you can start.
Yeah, thanks, Dr. Mukherjee. Thanks, Ashish bhai. So yeah, I agree with Dr. Shubham Pant that we do germline for majority of our pancreatic cancer patients, mainly to look at BRCA. But somatic is not something a standard or routine. Having said that, we have mainly out-of-pocket economy. So we do offer to patients that something like this sort is available if you want to avail. But I recently looked at the data from my last 2 years. Hardly 10% of them get a somatic NGS on day one. It's typically when they fail first line, that's when they said, okay, let's look at NGS and let's try and fish out for something. So that's point one. Point two about this case, usually 65 plus, 70 plus, Gem/Abraxane becomes easier for, at least in my setup, to use. But in this case, if I have a BRCA information or, taking from MD Anderson's data set, which I use pretty frequently in my practice, that if patient has a body tail primary, they tend to have more DDR pathway alterations. That's where I try and push for FOLFIRINOX. Otherwise, for head pancreas, Gem/Abraxane and FOLFIRINOX is by and large same. There was a large retrospective study from MD Anderson. So we kind of use that as well, information. So in this case, BRCA2, I would definitely nudge towards FOLFIRINOX. We've also started using NALIRIFOX nowadays in first line in India. I've had a couple of patients, one somatic BRCA2, at least 20 liver metastases, started him about a year ago. Now he has complete response. I don't know what to do, continue therapy or put them on part. Germline is negative. So we've had these, out of the box responses. Sometimes I think it's platinum rather than NALIRI here. But yes, I would go with a platinum in this case.
Maybe this is a question for you or any of our other Indian colleagues. Do you ever use Gem/Cis? I have used it in a couple of patients with BRCA mutations. That's something.
No. I have not used it, although I'm aware of the data that we can use Gem/Cis. GEMS's veliparib study came and it was very promising, but we kind of stick to gemabraxine versus FOLFIRINOX NALIRIFOX.
Perfect. Now we will go to move
Sir,
on.
can I throw one more thing in?
Yeah, sure, please.
Right. So Viraj, thank you for that. So I was involved in the NAPOLI-3 trial. That's the one for the NALIRIFOX, which we had done a global trial. And the important thing, for folks who kind of don't do this day in and day out is the difference. The big difference between NALIRIFOX and FOLFIRINOX is the oxaliplatin dosing.
True.
So it's 60 milligram per meter square versus 85 milligram per meter square. Maybe we didn't need such a high dose, right? That was borrowed from like the colorectal data in a way. So maybe you need, and that's why Viraj, that's one of the positives of that regimen is that you can kind of continue on with those patients with the NALIRIFOX regimen because they don't get that neuropathy as soon. They do get it, but they don't get it like we get with FOLFIRINOX. Tells you maybe we don't need the 85 milligram per meter square of oxaliplatin. Maybe we just need 60 or when the first dose reduction, and that was 50, which we really don't do. So there's a lot of scope. The other thing is the germline BRCA1, BRCA2 patients are very special patients. That means exactly what you're talking about, Viraj. I had the same, I had another patient. I've had actually multiple patients who, with BRCA1, BRCA2, they tend to do the best. They are very, very sensitive to platinum therapy. I had a patient, my longest living metastatic pancreatic patient was she went to 5 years. She had multiple liver mets and everything. And she went to about 5 years. I kept on doing this platinum, that platinum. I threw in some other drugs in the middle. She actually died of brain metastases, which is so rare of pancreatic cancer but the thing is, it's not like breast cancer. We just don't give time. These patients, poor patients, don't have time. But this patient lived long enough to get brain metastases. So it was very interesting that I've seen actually a brain metastasis in a couple of my BRCA patients because once you get 2 years out, these patients can start developing brain metastases, interestingly. So just watch out for that too. Sorry, Sarabjit, go for it.
Oh, no, that's actually an excellent discussion. And, I would like to add to that, there was data presented at, I believe, GI ESMO. They particularly looked at elderly patients, and the tolerance with the NALIRIFOX was actually quite well in patients over the age of 65 and 70 in the subgroup analysis. And I have used it in multiple patients in their 70s, and based on some of the reasons that Dr. Pant described, the tolerance seems to be really well. So, coming back to our case, this patient started FOLFIRINOX, and then finally the germline BRCA2 mutation showed was positive. So after 4 months, the patient had actually a stable disease. CA19-9 responded dramatically, but the patient started developing cumulative neuropathy and fatigue, which is something we commonly see, right? So my next discussion point is, after 4 months of platinum-based therapy with stable disease, not quite partial response, what would be your next step? Would you continue FOLFIRINOX, switch to maintenance PARP inhibitor, or de-escalate to 5-FU leucovorin maintenance? So maybe I'll start with Dr. Pant again.
Okay, maybe you can give me the question next time and on the second question. I'm just kidding. So it's a great. I think it depends really on patient characteristics. I mean, I know it's a cop-out normally that we use, but really, I think it really does. So I just think pancreatic cancer is a tough disease. And I think the symptoms of the disease are much worse than the symptoms of treatment, right? So when we look at FOLFIRINOX, gemabraxine, what does it show us? That patients actually have a better quality of life on FOLFIRINOX, which you would never think with the FOLFIRINOX, because they just feel a whole lot better. They get decreased abdominal pain, they start eating, they start gaining weight, all that. So my preference is I try to really, really press down on the tumor. I try to get to a point where I think I don't do the 4 months and switch. If the patient is having a lot of side effects, yes, I do consider that, right? Dose reductions and everything. I normally try to push them a little bit more, honestly, till I really see a good tumor response, because I know really these patients can get a good tumor. And when I really think, and I've had patients who've started with their CA19-9s in the thousands have normalized. And then I kind of let the thing off, and then I can give them either olaparib or kind of put them on maintenance and everything. So it just depends. But I think if they're having a lot of side effects, toxicity in the beginning, then obviously I kind of, I tend to move a little bit earlier. But I normally don't use the 4 months. Because as Viraj was saying, most of these patients do present with widely metastatic disease, multiple liver mets and everything, and the liver mets disappear, actually, which is great. But I tend to be a little bit more aggressive, honestly, in these patients to try to really get a good control of the tumor before I kind of introduce like a targeted therapy.
Thank you, Dr. Pant. Now, we will switch gears a little bit this time, and we will come to Dr. Lavingya like at last. But we will start with our surgical colleagues. If Dr. Shailesh and Dr. Aditya are here, in your practice, do you ever consider a consolidative type of approach with local therapies, including surgery, if a patient has excellent response to initial treatment, which I've sometimes seen with some of these BRCA mutated patients? And then I'll also ask Dr. Mondal what is his approach regarding radiation, like SBRT type of approaches. I'm not sure if Dr. Aditya is here or Dr. Shailesh is here. So maybe we can start with Dr. Mondal.
Yeah. So that's a very interesting question. Thank you for asking this. So overall, we all know that metastatic pancreatic cancer is having kind of not so good prognosis, and with best efforts and strategy, it actually doesn't give much improvement in overall survival. But if you see, there is probably a subset of population where we actually can utilize the BRT. And there is some data from Mayo Clinic, in fact, where they have actually showed that oligometastatic pancreatic cancer, when you give at least SBRT to primary tumor, metastatic site, that may help in some improvement in survival. But I would say that in my clinical practice, getting such patients is extremely rare. And with limited experience, what I have so far with SBRT in such scenarios are mostly for progressive primary disease when rest of the tumors are controlled. And one of my patients is surviving beyond 18 months so far after we did SBRT to the primary. And it was inoperable, so we did consider for surgery what you actually were asking for, Dr. Shailesh. So after extremely good response, remained controlled, started showing progress in the primary, we definitely discussed about the option of surgery. It was decided that surgery is not feasible. And then I did SBRT, and the gentleman, he himself is a doctor from MAMC, from one of our colleagues, is alumnus of the institute. So he's still coming to my follow-up clinic, and now it is almost more than 18 months. So yes, in a very selected group of patients where we can actually use our clinical judgment, it may give you good response, but I'll not advocate that as something that should be applied routinely to each and everyone.
Completely agree. And, you brought up a very important point, like oligometastatic disease, well controlled otherwise, but maybe there's progression of, one single lesion. We actually had such a patient that we discussed at our tumor board this week. Very young patient, disease was very well controlled, except for only one site in the liver. So obviously, we brought up the question of SBRT versus even surgery, because the patient was doing so well after almost 18 months. So I don't know if there's any oncosurgeon on the call, but if there are, we'd be happy to know about their perspectives on possibly doing metastatectomy in such cases. If not, then I'll go back to Dr. Lavingya. What is your approach? Do you typically go to maintenance PARP inhibitor, or do you de-escalate to 5-FU maintenance type of treatment when patients start getting beaten up?
Yeah, So I agree with Dr. Pant earlier that rarely I remember that having stepped down on platinum in a BRCA patient. Honestly, I'm not very much sold on Polo trial. 4 months is less platinum, I think, for these patients because we've seen dramatic responses with platinum. So I kind of go to at least 6 months minimum, and 8 months is also what we have done, and then just knock off the oxaliplatin, continue FOLFIRI, uh, and we have olaparib Indian generic available. It's very cheap now in India, but it's not very much convinced with Polo trial. So still stick to, and then reintroducing platinum at the moment CA 99 starts to creep up. Just reintroduce it back again. No, don't wait for the scans to show up because we kind of do monthly 19s 9. If it starts showing up, you reintroduce platinum. That kind of thing. That's what I do in my practice.
Thank you for sharing that perspective. So basically, as we discussed, the key takeaways from these cases would be, platinum-based chemotherapy would be mandatory. Germline testing is recommended. Maintenance PARP inhibitor could be considered if the patient has stable disease without progression. And what we saw in the Polo trial that there were some long-term survivors. So this is an option that we could possibly consider. But again, I personally tend to drag the platinum too whenever I can, if the patient can tolerate it. Okay, so now we will move on to our next case. And this is a very common case. I'm sure that all of us have, seen this type of cases. Probably we see them a couple of times a week in our clinic. So 58-year-old female patient, again, metastatic pancreatic adenocarcinoma. Patient presents with liver and peritoneal metastasis, had 2 peritoneal deposits, kind of isolated, so not diffuse carcinomatosis type of picture. ECOG PS1, the patient initially received FOLFIRINOX for 6 months. The best response was PR, but then the patient progressed and then was switched to GEM and Abraxane, received it for 4 months, and now the patient is progressing. The molecular profiling shows KRAS G12D mutation, VAF of 42%, wild type for BRCA1/2, PALB2, no other actionable alterations were identified. So, progressing on second-line chemotherapy, KRAS G12D mutation identified, what would you recommend? Third-line chemo, refer to clinical trial, off-label KRAS inhibitor, or best supportive care? So again, I would start with Dr. Pant.
Yeah, so I'll give you the quick, long answer. So just to about the mutant alleles for the folks who kind of, again, don't do this day in and day out, there's KRAS is not the same. So KRAS is 90% of patients with pancreatic cancer. Out of that, KRAS G12D, V, R, C, Q61, those are the big ones. D is 40%, V is 30%, R is 15%, C is just 1 to 1.5%. And the Q61 is about 5% of KRAS. So D is the most prevalent. What I've actually seen is the patients who come to my clinic, sometimes the folks are trying to give them, especially, we see patients, Anderson, from international patients also from different parts of the world, South America, China, India. Sometimes those patients are on actually adagrasib or sotorasib, which are G12C inhibitors. So it's important to know that the C is not the same as D. They're very different. So you're not hitting the target at all. So I wouldn't give any KRAS inhibitor. You would have to be specific for that. That given there are a lot of other RAS inhibitors in clinical trial development, obviously, we're trying to move them up. So the big one is a drug called daraxonrasib or RMC-6236. And that we just finished the second-line trial last year. And hopefully the readout of that trial should be sometime this year. And maybe available to patients as early as next year. But that's a pan-RAS inhibitor. Phase 1 looks very, very promising versus, a lot of things that we've seen in pancreatic cancer. There are multiple D inhibitors coming out of America and China and other places. So there's a drug called zoldonrasib, which is a D inhibitor. There's a drug from Estella's. I can never call its name. It starts with an S. I haven't learned its name, but that's a degrader, which is an IV drug. There's a drug from China from a company called Genfleet, which is called Verastem in the US. That's available. There's a drug from Insight, which was presented in ASCO GI. So why I'm telling you this is I think at least a year later, I hope to be discussing a completely different paradigm in pancreatic cancer. First of all, we just say, patients are, they're too sick, survival is low. But I do think there is a transformational shift coming in the way we treat pancreatic cancer. The D inhibitors, we have done a frontline trials combination with chemo with D. As you saw, the Insight trial was presented, which was like an on-off inhibitor, and they're showing single agent 35% response rate second line setting, higher than chemotherapy. So nality is about 16%. And then you see, in combination, even higher response rate. The data is a little bit early. So, right now, obviously, there is the challenge, though, is right now at this point, it's a lot of patients, too less slots. So we have patients in the US, international patients who come to us. Unfortunately, we aren't able to, sometimes give them access to the drug because we just don't have access to it because the clinical trials, and there are multiple other companies which are doing this. But long story short, right now it's not ready for prime time. However, we hope to change. The science is moving really, really fast.
I completely agree. I don't know how many patients I've referred to other centers because we didn't have a KRAS inhibitor trial, but fortunately we'll have some soon. So I would like to know what Dr. Lavinga's approach would be in such a case.
Yeah. So until a year ago, it used to be the last option, best supportive care. Virtually, we don't have a third line in pancreatic cancer. And by that 2 lines, 7 out of 10 would just say enough is enough. Having said that, since last 1 year, I've had 2 clinical trials at our center. I did one with SOS1 inhibitor, and they specifically looked at all comers failure. And it was not mainly for KRAS G12D, but 2-line failure. It didn't have any activity as far as I'm aware of. It's not read out yet, but whatever patients I enrolled had no activity. The trial that I am right now accruing is with PRMT5 inhibitor, but and it does not require MTAP loss. Because it's still phase 1A. So we're recruiting with third line with investigator choice of treatment. And we learned that again from MD Anderson's data that, experience that I was talking to Dr. Javle last week or last month, and he was saying that PRMT5 kind of allows the immune milieu to act on if you were to add a PD-1. And that's sort of things that we are doing, give PRMT along with and we have Indian nivolumab now, very cheap. So we're using something like that on clinical trial. I've enrolled 1 patient like that. The 1 PRMT monotherapy I didn't do anything. So yeah, we are waiting for this G12D drug that you guys are developing. And it will definitely, I agree with Dr. Pant, it will change how we treat pancreatic cancer. Just like an aggressive from third line has moved to first line in colorectal, in G12Cs. I think there is a way to do Gemabraxine plus this or Nalirifox plus this as a frontline option within just no time. So I'm too excited about these options.
We are all hoping for that and praying that it gets approved soon. There are too many patients in the clinic who need this. So again, the key takeaways would be that, that KRAS inhibitors, as Dr. Pant mentioned, are most likely going to revolutionize PDAC treatment. But clinical trial access is also critical for these patients right now until daraxonrasib gets approved. And unfortunately, there are very few slots for these studies.
So Sarabjit, sorry. So let me, thanks Viraj for bringing MTAP inhibitors to the spotlight. So we are doing a number of work with these PRMT5 inhibitors. So overall, so I'll kind of go over the whole, the interesting thing is Daraxonrasib is a pan-RAS inhibitor, like, 90% of pancreatic cancer patients, right? So we are launching a trial called Resolute 303, in which patients are going to be randomized to 3 frontline. So we move these patients quickly from third line to frontline. Resolute 303 will be frontline. Patients get daraxonrasib single agent, which is like in pancreatic cancer, if you say you've got metastatic pancreatic cancer and I'm going to give you a pill, it's hardly unheard of. But we've shown in phase 1 data set that it's actually got a response of up to 45%, right, in frontline. This is a press release by the company Revolution Medicine. Data will be presented soon at a major meeting. But so frontline, a pill with 45% response in pancreatic cancer, which is amazing. So Resolute 303 is that daraxonrasib versus daraxonrasib plus gem nab-paclitaxel versus nab-paclitaxel. It's a 900-patient trial, which will be launching in frontline. Interestingly, the KRAS G12D inhibitors, the daraxonrasib main side effect is rash. It's got other side effects. But KRAS G12D inhibitors are remarkably clean drugs. They have some nausea, mostly grade 1 or 2. So they can be easily combined with things like FOLFIRINOX, NALIRIFOX, or Gemabraxane. So most of the frontline trials that we are launching now with the KRAS G12D inhibitors are with any chemotherapy choice. So it'll be, physician choice of chemotherapy. You want to pick FOLFIRINOX, triplet or doublet, and you can go with that because these drugs are very easily combinable. Their side effect profile is very different from the pan-RAS inhibitors. And then coming to what you were talking about, MTAP inhibitors, there's really exciting. So one of the drugs which is the furthest along there's got a new name called navlimetostat. So it's a MTAP, it's a PRMT5 inhibitor. The company was Mirati before. Now it's BMS, Bristol Myers Squibb, same folks who make nivolumab. So they have this, they acquired that MTAP, the PRMT5 inhibitor. For why that's important is it's the concept. How it works is something called synthetic lethality, similar to the DNA damage repair pathway. If 20 to 25% of pancreatic cancer patients have an MTAP loss, okay? So if an MTAP loss, you accumulate something called MTA, all right, methylthionine. Anyways, you acquire, you kind of accumulate that. That binds to the PRMT5 enzyme, okay? So you have more MTA, binds to the PRMT5 enzyme. And when you give a PRMT5 inhibitor, it causes insult to injury, just like the DNA damage repair agents, right? Same concept, essentially. So synthetic lethality, same concept. An important thing, if you want to enrich your patients, you can look at patients with CDKN2A and 2B loss. It lies on the same chromosome in 9p in the kind of the same chromosome. So if you have MTAP loss, you almost have a 100% chance of having a CDKN2A or N2B, all right? But if you have a CDKN2A, N2B, there's about a 50% chance of having an MTAP loss. So remember, not every CDKN2A, N2B you can treat with an MTAP inhibitor. But if for whatever reason, the NGS that you're doing does not have that MTAP and you want to enrich it, that's how you can do it. And you can do the MTAP from, again, from NGS, next-gen sequencing. We're also starting off at MD Anderson, we've developed an MTAP IHC assay. So loss of the protein. So what happens is, so we see, because that we think if the protein is not being expressed, right, these inhibitors could still be active. So the field is moving really fast. We started a global trial called Mountain Tap 30. And it's essentially frontline patients get NGS, and they either get Gemabraxane or Gemabraxane with this MTAP inhibitor from BMS called navlimetostat. I'll just call it Navli for short. So we get Navli with or without Gemabraxane. Essentially, it's a placebo-controlled trial right now. We're still generating early data. Then I'm just going to finish with one thing, Sarabjit. I know I'm taking a little bit of time, though. I think we have some time.
Yeah, please do.
The thing is, we are combining now the pan-RAS inhibitors with the PRMT5 inhibitors. So we are taking daraxonrasib and we're combining it with the PRMT5 inhibitors. The one that we're combining it is called, the drug's name is Volpi. And it's a company's called Tango Therapeutics, small biotech out of Boston. But anyways, we're combining daraxon with PRMT5 inhibitors to see if we can increase the response. So the way pancreatic cancer is treated is going to completely change. We even haven't talked about Claudin. So there are Claudin ADCs, Claudin 18.2, zolbetuximab is for gastric cancer. Did not work in the DREAM trial in pancreatic cancer. However, we are seeing newer ADCs, antibody drug conjugates for Claudin 18.2, which could have activity in pancreatic cancer. So it's all like the field is really dynamic, changing really fast. So we hopefully can have multiple options for our patients here. Sorry, Sarabjit, go ahead.
No, completely agree. And that's a very interesting point that you brought up. we should also keep in mind the bispecifics, Claudin-directed bispecifics that are coming into this space. So really exciting times ahead. So hopefully in 5 years, the treatment of pancreatic cancer will change completely and mimic more how we treat non-small cell lung cancer today. But that's the dream. We will move on to our last case. This would be a very niche subset of patients of NRG1 fusion positive metastatic pancreatic cancer. So this is a 54-year-old male patient with metastatic pancreatic adenocarcinoma. Patient had, again, both lung and liver metastasis, ECOG PS1. Patient received NAB, paclitaxel, and gemcitabine for 5 months, PR achieved, but the patient is now progressing after 9 months. Again, there was an RNA-based NGS panel that revealed KRAS wild type and NRG1 ATP1A1 fusion, but otherwise no actionable mutations. So in patients with NRG1 fusion progressing on first-line therapy, what would influence your treatment decision? Access to zenocutuzumab, whether we would use it in a clinical trial versus compassionate use. Second-line chemotherapy and then zenocutuzumab, and then sometimes we often hear that RNA-based testing is not available or the turnaround time is too high. So I would, for a change, start with Dr. Lavingia this time, and then I will come back to Dr. Pant later.
So easy from my side, we don't have this drug in India. But interestingly, since last, I think so, year and a half, if we find a true KRAS wild type patients, we've started offering these patients this nimotuzumab along with our standard first line. Not seeing much great deal out of it. But that's the only thing we have, because it's rare to see a true KRAS wild type patient in pancreas. But generally they tend to do well prognostically. It's not 4 months, 5 months, 6 months progression. At least 2, I remember both of them went beyond 10 months on first line, not the typical of pancreatic tumor. But yeah, that is how we would do. So NRG1 fusion. So that that's the reason why in India we tend to not do somatic first line, because even if we do, we have nothing to offer unless certain clinical trial. Very recently, since last couple of years, there are centers who are doing early drug development. Like mine is there, Tata is there. But without that, it's just an academic exercise.
And what is the availability of, detecting fusions? Like, we have NRG1 fusion, we also have intract fusion, right? So the type of NGS panels that are used, do they detect RNA-based fusions, or is it mostly DNA-based alterations?
No, so they do have. But the thing is, we've built experience over past 4 or 5 years now. There is no comparison. Okay, so if you, let's not name the companies, but if you do like 1, 2, 3 in America, so if there is a patient whom I know personally, I would do either Foundation or Guardant or Claris, hands down, and not do it in India.
So, Dr. Pant, how would you approach this case? And you have mentioned about, doing a somatic mutation testing right from the get-go, which we also do. We have partnered with the company institutionally where we do this, but I would like to know, your take on this.
Yeah. So I think I completely agree with Viraj. Even in the community practices in the US, it's not common to do NGS for pancreatic cancer for a good reason, because we don't have drugs, right? In a way, and it's done, it's not done, patients can deteriorate really quickly. So it has to be the appropriate patient also. Remember, 20% of patients with pancreatic cancer, unfortunately, nothing is going to help them. They, they really don't tend to make it to 6 months, even 6 months. So we did a retrospective study of our data at MD Anderson in patients who progressed on the first line of chemotherapy and on the first scan. How did they do? And they did poorly. So if you have somebody gem-based, it didn't matter if you give them gem-based or 5FU-based, if you're progressing with the first scan, rapidly progressing disease, you're not going to do well. Maybe best supportive care is, if the PS is low, maybe best supportive care is the way to go. Now, coming to the longer question of, so mutational testing again is now coming to the fore in the US a lot more, especially early, because again, there are some clinical trials available for these patients, but it's still really, not for a bad reason, right? If you don't have a drug to treat these patients, then why would you make them spend all that money to do that testing, especially, kind of resource limited where people are paying out of pocket in India, right? So I completely agree with that statement. Hopefully that will change. But coming to pancreatic cancer, so I said 90% are KRAS mutant, 10% are KRAS wild type. So we've actually looked into our data set. KRAS wild type patients, prognostically, they do very well. So the way they do it is KRAS wild type can have up to 2 years median survival, not 1 year. So whatever you give to these patients, chemo, they'll do better. Whatever you give to them, they'll do better. Chemo, first line, second line. So that's why it's similar to what Viraj is saying. These patients tend to do better. Now, the other thing to remember is if you have a patient younger than 50 years of age, which is rarer in pancreatic cancer, but we are seeing more and more, maybe in MD Anderson, we just have a different patient population. If you're less than 50, you actually have a 20% chance of having KRAS wild type. So remember, if you have a patient that you really want to choose to do the mutational testing of RNA sequencing, you should do it for the KRAS wild type, for maybe patients less than 50 years of age. Out here, obviously, we would do it for everyone. But if you really were looking for wild type, in patients less than 50, about 20% can have KRAS wild type, a higher patient population rate. Patients from China can also, in Asia, other places in Asia, can also have a high percent of KRAS wild type, but kind of that 15 to 20%. So I think, but if you have a KRAS wild type, at least in America, we really do the RNA sequencing. And why that's important is I had a patient that I treated on the clinical trial of Xeno. He came to me from outside. Viraj, just like in India, it's the same thing in America also. We have all kinds of testing. Homegrown testing, the main ones are like Caris Foundation, Tempus, what people use. But, people use the homegrown testing also. So this patient, again, this was some time back, about 5-6 years ago, came to me, had treated with FOLFIRINOX, Abraxane, came to me, again, he was like 1.5 years out. So that tells you there's something different in this patient. He had a 50 gene panel done somewhere, DNA panel, KRAS wild type. And then we really did a biopsy. We did the RNA sequencing, came back as NRG1 fusion. We treated him with Xeno. He's stayed on for about 6 months on Xeno before he progressed. So again, it's not only Xeno for NRG1 fusions. Remember, you can have NTRK1 fusions, larotrectinib, entrectinib. The drugs, I don't know if they're available in India. RET fusions, you could pick up the RET fusions also. Interestingly, we did a global trial of FGFR fusions. With erdafitinib, or there are other FGFR inhibitors. I don't know if they're available in India for the bladder cancer. But anyway, so erdafitinib is a FGFR agent for bladder cancer. We did a global trial of FGFR, basket trial of other things other than bladder cancer, cholangio. Maybe you could use even pemigatinib in these patients. So for cholangio, so we had about 18 patients with pancreatic cancer in that. All were KRAS wild type. All were FGFR2 fusion. And our response rate for these previously pre-treated patients was 52%. So again, so if you find that, KRAS wild type, it's a little bit, so you really, if you have a KRAS wild type patient, maybe, and they're younger and they're fitter, maybe you should do make sure they get a good RNA sequencing, because not just the NRG1 fusion that you might catch, you might get an NTRK fusion, you might get, again, like I said, RET fusion, FGFR fusion, and you might get, obviously, NRG1 fusion. So it's a whole gamut of things you can pick up. And like I said, one of the the tips is that if it's less than 50 years of age, again, higher percentage chance of having a KRAS wild-type disease. Again, if you have a patient with pancreatic cancer who's going beyond a year and doing really well, you should suspect they're kind of a little bit different, right? Because do they have BRCA? Though you probably have tested that. Do they have this KRAS wild-type? Do they have a fusion? Do they have something else? So that's very important on these patients. The other thing is, I know Xeno is not available, but remember, you have to understand how that NRG1 fusion acts. So what happens is NRG1 binds to HER3, binds to HER2, and that's your downstream pathway, right? So basically, that's what Xeno does. It kind of binds to that kind of where the energy fusion binds and does not allow the dimerization, right? So there are other agents which are not that good, but I don't know if you have afatinib in India. That also, there's from a study called TAPER study. They did 4 patients, not a lot. colorectal, 2 colorectal, 1 pancreatic, 1 lung. But on this patient, actually, I used a afatinib after, and he still got a response, not for a long time, but got the response. So there's certain things you can use a little bit. I met recently an investigator from Italy who had given she was from Denmark. But anyways, they gave Xeno, they have access to it, and this patient progressed, and they did a biopsy, kind of looked at resistant mechanisms, and they found a resistant mechanism that actually erlotinib could work in that. So there's no harm in kind of, a little bit again, just because data doesn't exist, there are multiple reasons why it doesn't exist. Some of the drugs are just, companies just don't want to invest in it, right? So, but you can use others. So think about the pathway also. Even if you don't have the drugs there, maybe if you inhibit that pathway, you might get something, right? And some of these drugs are available in India, or, might not cost a lot, or some generic versions might be available. So there are other ways of looking at targeting this pathway with the NRG1 pathway, other than the Xeno, essentially. So that's what I would remember. The KRAS wild types are just very different. Patients, the other ones who have a longer response rate are the KRAS G12R, as in Romeo. So that mutation is very specific towards pancreatic cancer. Colorectal cancer has it less than 1%. You don't really see it in others other than pancreatic cancer. That works through a very different pathway biologically. So it can work through the PI3 kinase AKT pathway versus working through the RAS, RAF, MEK, ERK pathway. So they do differently. So we looked at our MD Anderson retrospective database. KRAS G12R tend to do the best amongst all the RAS, and KRAS Q61 tend to do the worst. So why that's important is because we have actually KRAS G12V drugs which are coming out, KRAS Q61 drugs which are coming out. So there are all these drugs coming out for these other mutations. But the RAS wild type is a very unique subset of pancreatic cancer patients. So I would definitely try, if you think they're doing well on the frontline therapy, they're getting a good response, I would make sure they have an RNA sequencing, because not only NRG1, you could find all these other fusions that potentially you could get access to drugs. Obviously, that's obviously a challenge, in India, but you're not just looking for NRG1 is what I'm thinking. You're looking for these other agents. And, just because FGFR inhibitor is used in cholangiocarcinoma, doesn't matter. You can use it if it's on FGFR fusion, you can use it in pancreatic cancer again. So all these different things you can consider. Go ahead, sir.
No, thank you for bringing that very important point. So I would also like to mention this. I don't know, but at least in our clinic, I have had at least 3 patients who asked me about the Spanish group study. It's creating a lot of buzz, right? So and they are asking me that can we use off-label afatinib, because that was one of the drugs that was used, which obviously is still not the case. So I'm really glad that you brought up afatinib in this particular scenario. But I agree that when some of these patients really respond so well, then we always think about what other options we could use for them. And regarding that, I would also like to spend the last couple of minutes maybe on locally advanced versus metastatic. The cases that I presented today deliberately were all metastatic. But in locally advanced cases, how aggressive we are with the systemic therapy versus incorporating, even if they have a molecular target, versus incorporating localized therapy like radiation or surgery. So I see that Dr. Aditya has joined, so start with him, and then come to Dr. Mondal as well. Like when you see these patients who are locally advanced, that they have major vascular involvement. Would you basically just say that we really can't do anything? Let the medical oncology colleagues take care of the patient, and we'll come back to it if there is an excellent response? Or how would you discuss this with the patient? Or do you say that surgery is never an option? Or do you say that it could be on the table, come back to me after 6 months of chemo? How do you discuss this with the patients?
Thanks for having me on this. See, what I would look at is what is the level of difficulty if I'm looking at a surgery. If it is a straightforward, if the portal vein is involved and we're calling it locally advanced, I would still consider a surgical option if available. Of course, it depends on the tumor biology and how aggressive it is, what is the size of the tumor, what is the extent of involvement. If I consider it as borderline resectable and I'm not sure if I can get away with an R0 resection, I would look at a neoadjuvant and then come back to it later if the disease is good. But many a times we see that it is partially encased. I would get away with a portal vein resection and anastomosis, or if I can do a SMA divestment where I can get away with an R0 resection despite it being a borderline tumor, I would still consider surgery. Of course, otherwise, I would go for neoadjuvant. I would never take surgery off the table unless there are definite indications that we cannot operate. Of course, we are not talking of metastatic here. It's locally advanced or borderline resectable. And I would keep my options open depending on what is the scenario.
Great. Dr. Mondal, how would you approach locally advanced cases at your institution from a radiation perspective?
Again, a very interesting scenario you have been discussing. So the challenges here is the tumor is not responding to first-line chemo, and progressive pancreatic tumor on first-line chemo is probably not having so good biology. It's going to be an aggressive tumor. So, but yes, we would like to give a trial of local treatment. We can have two different approaches here. If the surgery is not immediately possible, then one approach we give neoadjuvant chemoradiation, and the other approach for borderline resectable, we can follow a pathway of SBRT and then attempting surgery. So again, it will depend on the kind of local involvement, like whether it's involving splenic vein or whether it's involving splenic artery, whether it's portal vein or SMA kind of thing. So of course, it needs a very detailed discussion with our surgeon as well, that whether the surgical colleague believes whether this tumor will at all become operable in future. So that of course will have some implication on radiation planning, and and if it is believed that this tumor is not going to be operable in near future as well, then probably we are going for either neoadjuvant chemoradiation followed by further systemic therapy or SBRT followed by further systemic therapy.
Thank you. I know that we have just a few minutes, so first I would like to thank everyone for joining this meeting and sharing your perspectives. I personally learned a lot, so thank you, Dr. Pant, Dr. Lavinga, Dr. Mondo, Dr. Aditya, everyone. And if any of our participants have any questions, this would be time to ask that to our expert panelists.
Thank you so much for this lovely discussion.
Thank you.
Again, thank you so much for everybody spending the time with us in evening or morning or afternoon somewhere. And we're very thankful, what you do for the society and spending time. And last minute, we have Miss Nikita. I think she's from the Zoetic Pharma. If you want to just say a word, and again, for supporting this initiative.
Yeah. Hello, everyone. So on the behalf of Zoetic Healthcare, I just want to extend our heartfelt gratitude to our speakers and panelists and all respected oncologists for their valuable insights and participation in today's pancreatic cancer case-based discussion. So thank you so much once again, and wishing you all a very good evening. Thank you.
Okay. Thank you.
So I just wanted to, thank all our Indian colleagues for coming on. Just always amazed at we don't look at the finances and this and that. Just always amazed at what great work you guys are doing there. And I recently went for the 25th Maulana Azad reunion. So I'm officially an older oncologist, I guess. So you can look at the young generation here, Viraj and Dodal and everything. So I really want to, I think really the future is bright. Really appreciate you guys doing what you do there. We know it's not easy. So thank you for doing that.
And just to the SecOps journey, I met or we connected with about 400 plus oncologists, oncosurgeons from all over India, and it's a fascinating the amount of work or the way you guys do with the limited resources and constant grind, from morning to night with this patient's expectations and all um it's amazing. It's fascinating, and the way it started, with my mom's glioblastoma, right? That I got help from all of you guys there in this part of the world. I felt that why can't we do something and just bring everybody on the same platform? We are all the same color, same thing we want to do. Give it back to the society, give it back to the patient. Just exchanging knowledge, it could be helpful to all. Thank you so much.
Thank
all
you,
for-
everyone. Have a great
Thank
day.
you.
Or
Thank
you. Thank you.
Thank you all until next
Okay,
time.
Thank you, everybody. Bye.